Good evening, Dr. Manish. Thank you for inviting for the presentation. So there are excellent discussions that are going on. So many enlightenments regarding the liquid biopsies and liquid NGS. So today, my talk is regarding the osimertinib. We know that this is our favorite molecule whenever we find a EGFR mutation in advanced lung cancer patient. But let us see and revise why we are still using it after so many years after its approval. Osimertinib still stands as the standard of care in advanced EGFR NSCLC. So when we see the Globocon data by among the first 5 cancers, lung cancer stands at the highest incidence, both in terms of occurrence as well as the mortality, followed by breast, colorectal, prostate, and stomach. And lung cancer, when we see the mortality also, it causes deaths in more number of patients than it causes in a specified time frame, which means it causes more deaths than the incidence. In both sexes combined, when we see here, 11.6% of all the cases, they are lung cancer, and 18.4% of all the cancer deaths, they are due to the lung cancer. And we know that the cause of lung cancer, many of the causes of the various cancers are not known, but in lung cancer, the majority of causes, majority of the cases, they occur due to the smoking. They occur due to the smoking. And after 5 decades of knowing the cause, we still are fighting with the most common cause of the most common cancer causing, and which is the leading cause of death. The question is, why should we use the best drug that will maximize the benefit of EGFR mutation patients? Why should we use the best drug first? Why don't we use in the second line? Let us see the various first-line options that are available in EGFR mutant NSCLC. We have 3 generations of EGFR mutants, EGFR Tkis that can act against the EGFR mutant NSCLC. The first generation, erlotinib. The second generation is decamatinib. The third generation is the osimertinib. When we see the third generation osimertinib at the first line, the NCCN as of 2022, as of today, recommends osimertinib be the most preferred EGFR TKI in advanced NSCLC. May I request my senior colleagues and my colleagues to keep the mic on mute. So EGFR mutation, if it is discovered prior to the first-line systemic therapy, osimertinib is the most preferred drug. And of course, the first line and second line, second generation TKIs can still be used like erlotinib, afatinib, geftinib, and decamatinib. However, we know that in many of the places, EGFR mutation is not so easily can be done, and it takes some time. So when it is discovered during the after the initiation of first line systemic therapy in the form of chemotherapy, we can complete the options are to complete the planned number of systemic therapy cycles, chemotherapy cycles, followed by EGFR mutation, EGFR TK as the maintenance therapy, or we can even interrupt the systemic therapy and can start on the EGFR TKI. So both are options available and both are practiced nowadays. So when we see the difference between first, second, and third generation TKIs, the inhibition activity differs between the 3 generations, among which the first generation EGFR TKIs, they are reversible in action and they do not form the covalent bond at the ATP binding site. So it is reversible type of binding in the first generation, whereas in the second and third, it is irreversible type of binding. And these TKIs, they cause the covalent modification at the ATP binding site of the EGFR, resulting in this irreversibility. And when we see the ability to cross the blood-brain barrier, which is the most important feature we look at, but when we are treating the cancers like a lung cancer, which has high prediction for the CNS metastasis, the first and second generation TKIs, they have the minimal penetration into the brain, And among the first generation, we know that erlotinib has a little bit more penetration into CNS compared to the geftinib. And coming to the second generation, the CNS activity is not exactly characterized, but we know that there is some activity but it is minimal. Coming to the osimertinib, we know that there is a significant ability of the osimertinib, the third generation TK, to cross the blood-brain barrier, and so it has the intracranial activity against the brain metastasis also. What is the main difference? The main difference is in the structure as well as which is resulting in their chemical activity also. The first generation, geftinib, erlotinib, they are mainly anilinoquinazolines, whereas second generation is derivative of this anilinoquinazoline. And osimertinib is monoanilinopyrimidine. The structure as well as the activity of osimertinib is significantly different, and its binding, so as the binding with the ATP binding site. So osimertinib, from the previous slide, we know that is a third generation irreversible CNS active EGFR TKI, which can inhibit both EGFR sensitizing, EGFR T790M mutations, as well as the wild type of EGFR TKI. However, we know that the inhibition of wild type of EGFR is relatively less with osimertinib. And so the rash, which is the class side effect of the EGFR TKI, is very, very less with osimertinib. The main activity of osimertinib is against the two most common mutations of EGFR, that is exon 19 deletion and exon 21 L858R mutation. So it also inhibits inhibition of T790M when it is found in the baseline as well as in the second line, and it has very, very lower activity against the wild type of EGFR. And we do see that in the both preclinical activities and human trials also, it has significant intracranial activity. So as an oncologist, we do depend upon the data that has our most important endpoint that we look at in many of the clinical trials is overall survival. And the standard trial that has formed the basis for the osimertinib to come into the clinical practice is the FLORA trial. It is a randomized double-blind phase 3 study which has assessed the safety and efficacy of osimertinib versus the standard of care EGFR TKI, that is first generation TKI, in both locally advanced as well as metastatic advanced NSCLC. This is the FLORA study design. We know that the key inclusion criteria are the adult patients with a performance status of 0 and 1. Looking at the trial retrospectively, this looks like a little bit setback because obviously clinical trials adapt a strategy to include the best of the patients so that the clinical trial will be successful. But we do know that EGFR TKI can be given in ECOG performance status 3 or 4 also, and they do improve a lot. But in this trial, we can see that the population include the performance status 0 or 1 only, and two important mutations which we have discussed were included, and there should be no prior exposure to any sort of TKI, and stable CNS metastasis are allowed. So patients with brain metastasis are not included, which is actually a very important point for this study. And osimertinib is started at 80 milligrams per day, and against both geftinib and erlotinib at the prescribed doses. So these patients, they were assessed every 6 weeks to see the responses till there is a progressive disease. One of the significant point is that crossover is allowed whenever there is a progressive disease under first generation TKI, which is assessed by the independent review committee, and they are allowed to take osimertinib when they have T790M mutation upon progression. So the primary endpoint is PFS, and the secondary endpoint is overall survival and other factors like objective response rate and duration of response, and obviously the safety. When we see the osimertinib, which is the primary endpoint, that is PFS, the median PFS is 18.9 months with osimertinib versus 10.2 months the standard of care. And we know that in majority of the clinical trials that are taking place nowadays, PFS is the right measure. In fact, other variants of PFS, like radiological PFS, are being considered in many of the trials. But PFS and OS are the two important parameters. And majority of trials, it is seen that PFS is converted into overall survival, although it is not a compulsory phenomena. FLORA was powered mainly to see the PFS difference, and so it is the primary endpoint. When we see this forest plot, The PFS benefit is seen across all the subgroups for all the sex, for all the races, whether a patient is smoker or not, whether the patient has brain mets or not, and all the performance status of 0 and 1, and all the types of exon mutations of the EGF for both 19 and 21. One of the important points that is relevant to today's discussion is that whenever EGFR mutation is found by ctDNA is also the overall the PFS benefit has been seen in those patients also. When we see the overall survival in the final analysis, we can see here the median OS is 38.6 months with osimertinib versus 31.8 with the EGFR TKI, and we should keep in mind that many of these patients have received osimertinib after progression. The hazard ratio is 0.79, which means that nearly 21% of the patients, they events have prevented from the death by using the osimertinib. So median overall survival is greater than 3 years, whereas in the first generation it is less than 3 years. And osimertinib patients, they are more likely to alive at the second year point and third year point at 24 and 36 months respectively. So 28% of patients, they are still receiving osimertinib at 3 years. And we know that 22% of the patients were on treatment at the time of data analysis and data cutoff. And time to first subsequent treatment, this is the one of the most important point which we need to keep in mind while deciding whether we need to use osimertinib in the first line versus second line. Because osimertinib, we know that median time to subsequent treatment is 25 months, whereas for the rest of the comparator arm, that is the first line, it is only 13 months, which means they might have received as a chemo or the subsequent TKI after that. So osimertinib, whenever the FLORA detail, the results were declared, it has set an unprecedented landmark in terms of PFS in EGFR mutated NSCLC. We know that there is a gradual improvement from the first generation to third generation. However, in terms of safety, efficacy, and in terms of the benefit, overall benefit, we can see that osimertinib stands apart from the 9.5 months with the geftinib to 18.9 months with the osimertinib. We shall discuss the afatinib and decomatinib in detail in the coming slides, whether although they are much efficacious than the first line, their role is relatively less compared to the osimertinib as well as the first generation drugs. So coming to the OS curve, we can see here that in the Asian patients and in patients who are particularly in these Asian patients, it is crossing the line of unity, which means the benefit in these particular patients is doubtful. But we do know that whenever we are using in these patients, particularly in elderly patients and even with the patients with a poor performance status, osimertinib definitely benefits, and the definitely is palpably visible in those patients who are otherwise ineligible for chemotherapy. So PFS benefit is consistently maintained across all the subgroups, and OS benefit is in favor of osimertinib in majority of the subgroups. So this is the outcomes of Indian patients with the first generation TKI from the various real life studies, from AIMS, Tata TMH, and ADR. We can see here it varies anywhere from the 6 to 12 months, and some studies although has shown that it is 18 months. The real life, majority of the real life stories, the clinical trials, they show that the benefit is nearly 1 year, across the 1 year. So when we compare the second generation versus third generation, why we should prefer third generation compared to the second generation? So the trial itself has garnered some of the criticism, the decomatinib, the final analysis. But when we see the inclusion criteria, it is the comparator included geftinib alone, and erlotinib is not there. And it has started at 45 milligram per day decomatinib. And there was a racial analysis also, Japanese versus Chinese versus other East Asians and non-Asians, whether there is a separate benefit or whether there is a differential benefit. So the primary endpoint is PFS, just like osimertinib trial, and secondary endpoint is OS. In the FLORA, we have seen the details. Let us see the Archer exclusion criteria. One of the key lag point against the Archer trial is that it has excluded any brain or leptomeningeal metastasis. And in fact, any patient with interstitial lung disease or even non-infectious pneumonitis were completely excluded from the trial. And while osimertinib trial has recruited patients with CNS metastasis. When you see here, so this is the, whenever we analyze the Kaplan-Meier curves, what we look at is the separation of curves, how good it is, how early it is, and how wide it is. But here we can see in the Archer trial that for the first 6 months, the geftinib and the decomatinib arms are actually hugging each other and then only getting separated, which means that if any patient, if he progresses within the first 6 months, is no different from the patient using geftinib. But here we can see here in osimertinib trial that the curves are separated immediately at the from the very beginning in the first 3 months, and then the distance and the separation is maintained. And when we see the hazard ratio, it is 0.59 and it is 0.46. We keeping in mind that we actually cannot compare trial to one trial to another. The cross trial comparison may not yield the exact reports, but we do know that on the comparator arms, it is the first generation TKIs. The trial population may slightly vary, and definitely they are heterogeneous. But keeping in all these points in mind, we still do know that these first 6 months are really important in a patient with metastatic NSCLC. One of the most important criticism for Archer trial is that it is a hierarchical analysis of the overall response rate followed by overall survival, which means that whenever if the overall response rate is statistically significantly different between the compared two arms, only then OS can be significant. Here in the Archer trial, the overall response rates of 72 versus 75% between the first and second generation TKIs are really not statistically significant, and so the OS benefit that is being reflected here may not be actually analyzed in as a real benefit. So that is the criticism that is garnered against the decomatinib trial. So till the more prospective real life studies show the actual result, we cannot actually say that decomatinib has so much of benefit. But as of now, when we discuss the OS benefit, it is the osimertinib trial among the TKIs and chemo plus geftinib plus chemotherapy from the TMH trial. So this has mentioned in the Canadian consensus also, because the trial had a hierarchical stratified statistical design, and it did not meet the significance in terms of overall response rate, and so a p-value could not be given to the overall survival to the decomatinib. So here we have discussed almost all important points about the hierarchical gatekeeping procedure for the statistical analysis, etc. Let us see the serious adverse events in the decomatinib versus osimertinib. Those reduction were needed in nearly 2/3 of population, that is 66%, whereas in the osimertinib, dose reduction is needed only in 3%, which is slightly equal to or less than the first generation TKI. Serious adverse events, that is grade 3, grade 4 side effects, are seen in 27%, whereas the adverse effects with osimertinib are only 4%. And coming to the death, adverse effects, all the side effects that are leading to death is nearly 10%, whether it is 2% with the osimertinib, which are really these points, the safety endpoints are the ones we actually need to look at while selecting the TKI. Coming to the other second generation that is afatinib, we can see here up to 12 months, afatinib at the end of the analysis, which has failed to improve the OS versus geftinib in the Lux-Lung 7 trial. So again, keeping in the mind that this is a cross-trial comparison, we can see here in the afatinib trial, stable brain mets were included, but there is no OS benefit in the trial, and up to 12 months, this the curves do not get separated, and so we actually cannot say that afatinib is much better than geftinib. In the same way, up to 6 months, the curves are hugging each other for the decomatinib, and osimertinib, we have seen this, the early separation of the curves. And one of the important point we do consider in patients already having brain metastasis or who are at risk of brain metastasis due to the heavy burden of the disease in the systemic disease below the brain is the intracranial response of the TKI, which we are actually selecting. So when we see the isolated CNS progression, it is better with the third generation compared to any previous generations. So first and second generation, they have very poor distribution in the brain as well as CSF. And third generation, it has a clear intracranial permeability. So in FLORA trial, both systemic and intracranial efficacy were analyzed, and it is shown that osimertinib definitely have a better intracranial penetrance and efficacy. So not only in the preclinical studies, in the clinical trial, that in the FLORA, we have seen that patients with the CNS metastasis and so with the treated CNS metastasis, osimertinib, the PFS is 15 months, whereas the compared to gefitinib is 9 months. In treated CNS metastasis, the overall survival is also better with the osimertinib compared to the gefitinib. We can see here a good hazard ratio of 0.48, which means that the 52% of intracranial events are being prevented by using osimertinib compared to the gefitinib, which is really significant that half of the patients, they do not have intracranial progression when we use osimertinib compared to gefitinib. So these are the graphical representation of the benefit which we have discussed in the previous slide. That is the reason why osimertinib is included as the preferred EGFR TKI in advanced stage disease in NCCN as well as in EMA as well as by DCGI. And tolerability profiles we have seen compared the osimertinib with the dacomatinib. And when we see with the EGFR TKI of the first generation, which is really well tolerated in many of the trials. So osimertinib has lesser grade 3 events compared to the first generation TKI. And any EAE adverse effect leading to discontinuation is 41% in the osimertinib, whereas it is 50% in the gefitinib. We can see here, and we also know from the practical experience, it is a very easy and tolerable drug, except for a very few patients who might have QT prolongation and other side effects, who account for less than 5%, hopefully. And we can see here in the FLORA, it is less than 1% of paronychia, dry skin, stomatitis, whereas it is 30%, 37%, 22% in the comparator arm. One of the important side effect is the diarrhea. However, it is almost equal and as much as with the first generation TKI, but it is easily manageable. So coming to the safety data of Archer and FLORA, which we have already seen, those reductions are really significant in dacomatinib, even compared to first generation as well as the third generation. And we know that lung cancer is a geriatric disease in majority of the settings. So dacomatinib, how it performed in the geriatric use, compared to the young patients, they have higher incidence of grade 3 or 4 adverse reaction, that is 67%. There are more frequent dose interruptions because of polypharmacy and because of the poor tolerance, and there were more frequent discontinuations and dose interruptions. So why we should consider osimertinib as the first line rather than in the second line? The reasons are many. One of the most important reason is that whenever a patient is affordable and when we have access to the osimertinib, why should we prefer in the first line? This is the same reason as that whenever we have a connecting flights, there is always a probability that we will miss the connecting flight. But when we have a single flight that is reaching at the destination of what we want, so why not catch the direct flight and take the connecting flight? The reasons are as below, because when we use the first generation TKI or second generation TKI here, so many of the patients, they do miss the flight because of the poor performance status. So we can see here nearly 1/3 of patients, they do not receive second line therapy at all. And 1/3 of patients, they do not have T790M mutations, bearing which we cannot actually give osimertinib. Some of them might have histological transformation as well. We may not know because of when we don't do the biopsy. So approximately, we are passing on the benefit, saying that for this, quoting the 2 months of extra PFS when we used in the second line, by combining first 10 months versus second 10 months, only 1/3 of patients will ultimately be using the osimertinib. So weighted average PFS is 15 months with the standard of care TKI in first line followed by no therapy. with chemotherapy in one-third of the patients and osimertinib in one-third of the patients. So 33% of patients only ultimately will receive osimertinib in the TKI whenever we are planning it as a second line rather than the first line. So this is the approximation of how many patients may not be eligible for the next generation TKI. So one of the study that is quoted that osimertinib, why we should prefer the osimertinib in the second line but not in the first line, is the geotag study, which has shown that using afatinib in the first line followed by osimertinib may be more better than using osimertinib in the first line. So let us see what are the backlogs of the geotag study. It is a retrospective study, and majority of the patients who actually matter while we are doing a prospective study were excluded from this study in the form of those who are T790M baseline were excluded, and patients who died on the first line afatinib were not included in the analysis, and those who could not receive the second line therapy has been excluded from the analysis, which actually have a potential potential to influence the analysis and so the outcomes. And most of the patients, they have higher incidence of del19. We know that del19 patients do better than the exon 21 mutations. And so they have initiated osimertinib greater than 10 months before the enrollment. And so the overall duration of the osimertinib, the duration is really, really less. So we cannot put geotag, or we cannot actually consider geotag as the the real evidence when we are considering osimertinib to decide between the first line versus second line. These are the reasons which we have discussed, that we may not know who will develop EGFR T790M mutations, and not everyone will be fit enough in the second line to receive the second line. So coming to the summary, osimertinib demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years. It is a new benchmark of osimertinib, which may be met or crossed only by osimertinib plus chemo trial, which FLARA2 trial, which is still going on. FLARA is the first time an EGFR TKI PFS is directly converted into OS. Nearly 30% of patients still remained on osimertinib for 3 years, and all the patient subgroups, they have consistent benefit in terms of PFS, and majority of the subgroups have OS benefit. So safety profile, we have seen that it is really appreciable in terms of good tolerance, both for the patient as well as the physician. I thank you for this opportunity, and I end my talk.
Thank you, Dr. Pradeep, for this wonderful presentation. So I think we are already getting late. In the interest of time, we can allow one or two questions, if any. Otherwise, we'll have Dr. Pradeep you in the panel discussion as well. So you are seeing plenty of lung cancer patients in Assam Cancer Institute, I think. So have you changed your strategy? Because few of the patients, they're not that well-to-do that they can afford osimertinib. Do you try to sequence your patients, or you still say osimertinib for all of them, or you selectively use osimertinib in exon 19 and give L858R another chance of some ramucirumab or any other drug, or dacomitinib?
Yeah, thank you, Dr. Manish. The challenges that I face here in Assam is quite different from those in Delhi and RGCI. If the patient is not affordable for osimertinib in the first line, they are not affordable in the second line also. So in all those patients who are affordable for the osimertinib, definitely it is my first line choice. There is no second thought about that. But in those patients who are not affordable for the osimertinib, I use the poor man's osimertinib, that is gefnib plus chemotherapy. So
so you are doing gefnib plus chemotherapy. So I have heard about this combination very long time after. So I have not heard about this combination in near time. So pemetrexed and gefnib are you giving? For how long you are giving?
Sorry?
For how long you are giving that combination?
So I have given this combination while I was in Visakhapatnam also, Vizag TMS, and then I am continuing here. So currently I am using this combination in two women who are greater than 60 years, and the tolerance is quite good. So going on.
So you don't find plenty of toxicity with that combination?
Yeah.
Okay, thank you so much. So